This week we'll be talking about abnormal uterine bleeding, and this is Katrina. So a lot of different conditions can kind of get wrapped up under the umbrella of abnormal uterine bleeding. So I think to make this topic a little bit more digestible, we're going to be thinking about different ways that we would assess all the conditions, because a lot of the questions that we would ask and the things that we would assess overlap. So we're going to talk about it all together and kind of tease out what would be a little bit different from one type of condition to the next as we go along. So first we'll go through the different types of abnormal menstrual patterns, how we would define those. And then we'll talk about how we would collect subjective data, so history taking, and then how we would collect objective data, so that would include our physical exam, labs that we might order, diagnostic imaging, and then we'll move from that to talking about ultimately what's on our differential diagnoses list, and then based on what we end up diagnosing her with, how we would develop a management plan based off of that. So to get started, amenorrhea would be, A means absent or none, so it's basically saying no menstrual period. So men means month. You'll see meno in a lot of these. So meno means month, and then rhea means flow. So no monthly flow. So you could define that, at least if she hasn't had 3 cycles, you could call that amenorrhea. Oligomenorrhea means it's really infrequent. This might be somebody who just doesn't know when she's going to get her period. It could be a few times a year. She might go 6 months without. Then she might have it every 30 days a couple times. So just can be pretty sporadic. But oligo means few. So few monthly flow. And then polymenorrhea is if we're having a regular cycle, but they're pretty close together. Metro means irregular cycles. So somewhat similar to oligo, but rather than focusing on there ultimately being very few cycles, this is saying we just really don't know when it's going to be. Maybe it's 15 days and then it's 30 days. So they won't be quite so spaced out likely as opposed to oligomenorrhea. Then menorrhagia means heavy flow or heavy cycles. And then menometrorrhagia is combining the two, so irregular heavy cycles. And then intermenstrual bleeding, so bleeding in between regular cycles. To a certain extent, all of this is getting lumped into just calling it abnormal uterine bleeding, or AUB. So in terms of diagnosis that you're working up, none of these are technically diagnoses. These are symptoms of diagnoses. But sometimes when you're working things up, you need to kind of have a placeholder diagnosis. Like why are you ordering these labs, for example? The ICD-10 code could be menorrhagia. But we're moving towards just using AUB as kind of our umbrella term for all of it. Okay, so then to just expand a little bit on some of these, with amenorrhea, we can divide that into 2 categories, primary amenorrhea and secondary amenorrhea. So primary is the absence of menarche by age 16, so she just hasn't gotten a period yet, and she's turned 16. So as you start to think about the conditions women are coming in with, you want to start to think about your differential diagnosis list. So that happens even before you walk in the door, as soon as you know what her chief complaint is. So causes for this, it could be that she is getting a flow every month, but there's some kind of an obstruction, like hymen, that is causing us to not see the flow. Or it could be that she's got a chromosomal abnormality or a Mullerian agenesis where certain organs just haven't developed enough where she'd be capable of having a period. So while we say to wait till age 16, if a young woman comes to you and it's been 3 years since DLARC, when she's had breast development, then it would be worth working it up sooner. So if she's 14 and she's just starting to have breast development, usually it takes 2-3 years after DLARC for menarche to develop, so it's okay to give it a little bit more time. But if she's had breast development for a while already, like 3 years, then you might want to start working this up sooner. So that's amenorrhea. So if she's younger than that, then really it's about anticipatory guidance, right? Whereas with secondary amenorrhea, that would be the absence of a menses for 6 months with a woman who previously has had menses. So if somebody has been having regular cycles and then out of nowhere she's not having them anymore, that would be secondary amenorrhea. So as you think about building a differential list for her then, the top 3 reasons for secondary amenorrhea are hypothyroidism, hyperandrogenism, and pituitary adenomas or tumors. So those should be the top 3 things on your differential list as you want to think about what kind of labs you'll draw, that kind of thing. But then you also want to consider eating disorders, excessive exercise, especially when those two come together. Athletes, that's something to be watching for. Medication she's on might be causing it, systemic illness or stress, cancer, for example, and then chemo even more so. So all of those would be things that you're thinking about when you think about how you're going to work her up. All right, so then dysfunctional uterine bleeding, or DUB, is kind of an umbrella term for painful periods, heavy periods, irregular periods. I would say more so irregular and heavy periods, but you'll see the term used as an umbrella term for all of these as well. So menorrhagia, just to define it a little bit more for us here, to think of it as a heavy flow, it's her having to change pads or tampons every 1 to 2 hours during her menses, or if her period lasts a long time, which would be considered 7+ days, or if throughout her menses it's totaling 80 mils or more, that would be considered a heavy menstrual cycle. With the use of Diva cups, actually being able to quantify it is a possibility. So for the most part, you're going based off of her history for what she's telling you rather than trying to quantify it that way. Dysmenorrhea we can divide into either being primary or secondary. So primary dysmenorrhea means that she's having cramping either right before her period and then during her period, whereas secondary is implying that it's due to some other kind of pathology. So usually with secondary amenorrhea, she's had periods that have been fine for a long time, and then it's more recently that she started to have quite a bit more cramping. So pathologies, it could be like endometriosis or leiomyomas, which are fibroids, adenomyosis, pelvic inflammatory disease. So you can see primary is kind of what we think of when everybody says they might be getting some cramps with their periods, versus secondary dysmenorrhea means there's something else going on. We need to hunt down and find it. All right, so then considerations. Anytime you're looking up dysfunctional uterine bleeding, you want to think about, could it be that she has anovulatory cycles? Does her pattern sound like she's regularly ovulating or not? If you go back to our normal menstrual physiology, you'll remember how we talked about how you have your FSH that's being released starting from the beginning of the month, and that's causing estrogen to be released from those follicles, and then that's going to build and build and build, and then LH is released. We have our egg, and then that causes the follicle to turn into a corpus luteum and start producing progesterone. And then that progesterone is going to climb up, and then as the corpus luteum starts to come down and dissolve, then the progesterone levels will go down. And as progesterone levels go down, that's what triggers a period. So if somebody's having regular cycles, we can basically assume that she's also regularly ovulating. So with our women who are coming in with heavy periods, that's likely the case. But if she's going 3-4 months without a period, or it's just really sporadic, then we have to wonder if maybe her cycles she's not ovulating. In which case, when we think about what might be causing this, that could be something with the HPO axis, so something around our FSH, LH loop is off, so thyroid issues, pituitary gland issues, like if we notice high prolactin, if there's a tumor there. PCOS might be a possibility here. Different kinds of endocrine disorders, which I already alluded to. Chronic illness, psychosocial issues, possibly perimenopause. So we think of menopause as being when somebody hasn't had a period for 12 months, but perimenopause is the 10 years leading up to that. And perimenopause tends to have some anovulatory cycles where periods are starting to become more sporadic and irregular. So if somebody comes in and they're 44 and this is an issue for them, you're going to think about it differently than if she's 27, right? So sometimes we have a normal answer for what's going on, and so us understanding normal really well is then helpful for us to be able to tease out what might be abnormal. Now, if it does sound like she probably is ovulating every month, then we want to think about, might there be some kind of anatomic lesion like fibroids, maybe a congenital malformation with a partial obstruction, possibly endometriosis, possibly an IUD being the cause for pain, or maybe if she has like a copper IUD, that could be the cause of her excessive cramping or heavier flow. So these are all things that we're thinking about. And then let's see, excessive or unopposed estrogen. So this is something we need to regularly think about. So when a woman has a normal menstrual cycle, estrogen dominates that first half of the month, and the progesterone dominates the second half of the month. And estrogen tends to make the uterine lining grow thicker, whereas progesterone ultimately is going to thin it back down again. So if somebody's not regularly ovulating, that means they're having the estrogen dominant half of their cycle, the proliferative phase, but they're not having the secretory phase with the progesterone. So we think of that as being unopposed estrogen, where she's not having progesterone to balance out the estrogen. And why that's concerning is because unopposed estrogen, if estrogen is the only hormone that is dominant in a woman's cycle, that means that her endometrial lining can continue to grow without ever being checked, and progesterone telling it to kind of thin back out again. And with enough time, that can lead to precancerous lesions and ultimately to endometrial cancer. So anybody who's having really irregular periods, especially like with oligomenorrhea, where there might be really long stretches without, it's important for us to make sure that her uterine lining is becoming proliferative. So then that's on our radar. And then the last thing we want to be thinking about is ultimately we're trying to figure out what's causing this issue, and then how can we make it better for her. And then in the midst of this, we also should think about if heavy bleeding is at the forefront of her concern, might she be anemic? So our questions and things that we're asking about should also have that in mind. Are we losing too much blood? Okay, so subjective data collecting. So for past medical history, we'd want to know about any major chronic illnesses, renal or hepatic, or adrenal or thyroid conditions would be particularly pertinent when we're thinking about hormonal disorders. For past surgical history, all of it, but then especially as it relates to anything GYN or the brain or cancer, and any treatment that might have been involved with those two. Okay, so then obstetric history. Does she have a history of infertility, ovarian cysts, any ectopics or abortions? Types of deliveries, were they vaginal versus cesarean? Were there any complications with those, particularly if it related to infections or surgical complications that perhaps might have left scarring that may be contributing to what we're working with now? Also, is she still nursing? Because that's definitely going to impact her menstrual cycle as well. So that would be an important piece of her history. Sexual history, partners, any recent infections, history of STIs, that sort of thing. Let's see, moving on to menstrual history then. It'd be good to know our menarche. Did she start early? Was it a typical time to start? Phelarche, as well as secondary sex characteristics, if what we're working up for her, especially with amenorrhea, if we're wondering more so about development. But then the basics for menstruation, so how far apart are they? How long do they typically last? Does it tend to be heavy, light? I think It's helpful to have people quantify that in terms of pads or tampons. How big are your pads, that kind of thing. Sometimes people don't necessarily have a good sense of how they would compare to other people. And then, of course, any associated symptoms like cramping. And then with those, what has helped, what tends to make it worse, what tends to make it better, asking those kinds of questions. How high would she rate it on a pain scale? So working up cramping the way you would for old GART. Great, so then review of systems. Again, a lot of this will depend on which one you're working up, but thinking about like thyroid symptoms, like recent weight gain, weight loss, anything with like temperature instability, fatigue, then thinking about those anemia-based questions, so dizziness, fatigue, headaches, thinking about if she does have say a pituitary tumor, any visual changes, headaches can be associated with that too, any nipple discharge, and then anything related to estrogen too. So is she experiencing hot flashes, vaginal dryness? What does her acne pattern look like? Like symptoms of virilization, like acne pattern, hirsutism, male pattern baldness, that kind of thing. And then abdominal or GU pain. It could be that her menstrual cramping is related to something else in her GU or abdominal area. So asking about that. Insomnia. So really do a nice thorough review of systems. And then for lifestyle, asking about nutrition. And then this would be our opportunity to really ask some good questions that could tease out if we have any issues with eating disorders too. And then exercise and lifestyle pattern with exercise. More so here we're thinking if it's excessive, because excessive exercise can cause decreased estrogen and can really influence our menstrual cycle that way. And then drugs, alcohol, smoking can all play a role too. And medications and supplements, we want to get a full history there, particularly contraception, because certainly that can influence our menstrual cycles too. Okay, so then our physical exam, we want to get our basics, so our vital signs, age, height, weight. So our BMI can play a role here. Obviously our age can too when we think about how menstrual cycles change throughout the lifespan. And then blood pressure and pulse, we're thinking too about anemia, but also for blood pressure, we're thinking about would it be smart to start a COC, that kind of thing for contraception, in case that's where we're headed. So general appearance, what does her development look like? So that's Tanner stages, right? And then acne, hair pattern, acanthosis nigricans, if you're seeing that thick line on the back of her neck, for example, that can imply insulin resistance. Then we want to feel her thyroid gland and make sure that that's normal, no abnormal masses or enlargement. And we want to do a breast exam, again thinking about development. And again, you can tailor this based on what she's coming in with. So breast exam, and particularly thinking for like primary amenorrhea, may not be necessary depending on what else she's coming in with. So I'm being really thorough here, and then you're going to pull out the questions that apply to the woman in front of you. So then genitalia, pelvic, that's going to apply to everybody who walks in the door with any of these issues. So again, we're thinking about development. Is there any trauma? Are you noticing any obstruction that could either cause flow to not be able to come out, or even people who are saying that a few days after their cycle ends, then they have a little bit more bleeding. Sometimes there's a pocket that's collecting blood that then maybe works its way out later. So thinking about all these things. When you look at the cervix, are there polyps? Does it look particularly friable? Like if you touch it with a Q-tip, does it easily start bleeding? Might she have an infection? That would explain some irregular bleeding too, right? If she's just noticing a little bit of spotting that's not correlated with her cycle. And then for the vagina, you're thinking about color, moisture, rugae, all these things that show that it's really well estrogenated. So if we're thinking maybe perimenopause, or even somebody who's perhaps going through ovarian failure early, so essentially going through menopause at age 28, for example. Does her vagina look like it's got plenty of estrogen? So that good rugation, good pink color, moisture, etc. And then uterine size and shape would be important when we're thinking about fibroids, or even is it there? And then our ovaries, do our ovaries feel like we might have cysts, or that maybe we can't find them and that might actually matter? Sometimes we're not able to find them, but if it's somebody who's never had their period, we might even be wondering if they have them. While you're conducting your physical exam, you may want to collect some of your labs while you're there. So you might want to do a pap smear if it's needed. And then an endometrial biopsy would be something worth considering, particularly with irregular or sporadic bleeding. So this would be recommended for all women who are over 35 if she is having an irregular bleeding pattern, like if she's having regular cycles but then is spotting in between, for example, or for any woman who's gone through menopause and has started bleeding again. So she's had 12 months worth of no cycle and now she's starting to bleed, as well as anybody less than 35 who has a family history of ovarian or breast cancer, or colon cancer, or endometrial cancer. Those are kind of the four that go together. So ovarian, breast, colon, endometrial. For thinking about genetic cancers, or any kind of history of tamoxifen use, or chronic anovulation, or obesity, or estrogen therapy, or diabetes. All of those would put people at an increased risk for endometrial cancer, and an endometrial biopsy would get a sampling of that endometrial lining so that it could be tested to make sure that it's okay. So you could do that, and then STI screening or a wet mount if that was warranted too. So sometimes infections can just cause the cervix to be really friable, and that could be where our bleeding is coming from, for example. So all things to consider. And then I have just a little bit more information on endometrial biopsies here, just so you've got a brief overview. So indications, again, abnormal menstrual bleeding, that's what we're talking about. Bleeding after menopause. Absence of uterine bleeding, where you're wondering, is the lining just building up, building up, building up, building up? Now, somebody who sounds like they're going through a fairly healthy perimenopause, I wouldn't be concerned about this, but just depending on her clinical picture, that might be something worth considering. And then pelvic pain, it would be something worth considering as well. So it could detect infections, like endometritis. It could detect polyps or fibroid tissue. And then endometrial cancer, this is our gold standard for diagnosis, and this is the main reason you're considering doing it. And then contraindications would be pregnancy, obviously, and then any kind of vaginal cervical infection or PID. We wouldn't want to be dragging any infection up into the uterus. So that's why that would be a contraindication. So this is absolutely something that you can do. It's really painful, so I think that's an important part of anticipatory guidance for patients. It's pretty uncomfortable, and it can cause some bleeding, and sometimes an infection can be carried up, and sometimes the uterus can be perforated. So not common for those last three. Well, potentially the second one, but infection and perforation, this is the same way you give anticipatory guidance before inserting an IUD. And then you set it up similar to an IUD. So you put in a speculum, you'd apply a tenaculum, and if that doesn't sound familiar yet, you'll learn about that at the first intensive. So you apply a tenaculum to the anterior cervix to stabilize it. So they're like little pinchers that you'll kind of pull on so you can straighten out the uterus. And then you'll sound the uterus. So that's putting in a stick that looks kind of like this. It's like a rod that goes up into the uterus. You can see exactly how far in it is. It's like a measuring stick. That's a thin rod. So you can know, okay, it's 7 centimeters in. And then all of that is the same as an IUD. And now, unlike an IUD, you're inserting this device. And basically, this is a plastic tube that has a few holes on the end. And then it starts, though, with this piston, this plastic rod inside it. So you put the whole thing up into the fundus, and then you pull back the piston, and then that causes suction up in here. And then once that's done, you are twisting this like back and forth, kind of in a circle while you go in and out of the fundus. And then that causes this whole area to fill up with endometrial tissue because of the suction you've created with pulling back the piston. So there's a few different ways to do it. You can either go in and out while twisting back and forth, or you can kind of think of yourself as going in four corners, if that makes sense. If you're facing the woman, kind of upper left, upper right, lower left, lower right, but still going back and forth. Either are considered acceptable. Basically, we just want a sampling of endometrial tissue from the whole inner part of her uterus. All right, let's see if we missed any steps here. And then you'll start to see that the tissue fills up on the outside, and then that's how you know you can take it out. You don't want to take it out and put it back in because you don't want to cause infection, but also as soon as you take it out, you've lost your suction. Okay, and then once you take it out, you put the piston back in the tube to make all the endometrial tissue squirt out the end, and then that's what you're sending to the lab. You can absolutely do it. I know it sounds kind of scary, but it's one of those things where you're just going to look at it before you do it, and especially once you're used to doing IUDs, I think this is less complicated than putting in an IUD. Okay? So know that that's something that you can collect. That's not something you'd have to send her out to do. And women appreciate not having to be tossed around too much. So if they can stay in our court for a little bit longer, they're going to appreciate that. And then it could be that the endometrial biopsy is fine and you can keep treating her and she doesn't need to see a lot of faces in the process of trying to figure out what's going on. Okay. Objective data. Labs. So what kind of labs do we want to consider? So I've got a lot of labs on here, and I'm not saying that means we're drawing all of them, but these are all things we should consider drawing based on why she's coming in. So painful periods, no, we don't need to do a pregnancy test, but irregular cycles, no period, that would be worth ruling out before we go too far down any other rabbit hole, right? Urine pregnancy tests are cheaper. You can do them right there in the office, and then and then you can decide what you want to order for blood tests after you already know that that's negative, rather than doing a serum HCG. Okay, so thyroid. Definitely hypothyroidism can cause women to not have a cycle or to have irregular cycles. So sometimes hyperthyroidism, but usually that's more so with really heavy periods. So doing a TSH with a reflex to a free T4 is a great place to start for assessing the thyroid. And that's going to be basically a must on almost everybody coming in. So you're checking your thyroid. And then again, if we've got irregular periods or no period, a prolactin level is going to be able to help us rule out if she might have a pituitary tumor. And then our FSH and LH and estrogen together. Ideally, if we can draw all those on a cycle day 3, that's our best way to really be able to kind of compare numbers and know, because like estrogen levels can vary quite a bit depending on what day of a woman's cycle you're drawing it on. Now, if she hasn't had a period in 6 months, we're not waiting until she has a period to draw it on cycle day 3, right? That's not very practical. But if there's some sort of regularity or you know it's coming, then you might want to wait and just do it on cycle day 3. And then I'll kind of give you a better picture of what's going on. So if she's got a high FSH and an LH with a low estrogen, that's going to indicate either perimenopause or moving into menopause, right? Because it's saying that our follicles are responsive to FSH. That's why there's more FSH. Or it could also mean ovarian failure. So if she's 31 and is trying to get pregnant and you're drawing these labs and there's a really high FSH, that's saying her ovaries aren't responding. Versus if she's a low FSH and LH and estrogen, then that makes it sound like there's something going on at the hypothalamic level, and that's where our amenorrhea is based in. Okay, so mid-luteal progesterone, that would be a way that you could confirm that she is indeed ovulating. So again, if you're able to get at her cycle about halfway through between when you think she ovulated to when she's expecting her period again, if you draw labs for progesterone then then that would be, and it's a good number, then that's indicative that she is indeed ovulating. So that's a great way to confirm she's ovulating. Now, if she hasn't had a period in, say, 6 months, then you could do a progesterone challenge test. Basically, what that would mean is you would prescribe her progesterone that she'd take every day for like a week, and then you'd expect her to start bleeding once she stops taking it within the next week. Usually between 2 days and a week or so, she would have a withdrawal bleed, because that's what prompts the menstrual cycle, is withdrawing from progesterone. So then if she did have a withdrawal bleed, that would confirm the presence of estrogen. So yes, there's estrogen there, and yes, there's an intact outlet flow as well. So if she's never had a period too, that would be a way for you to know that there is an outlet flow. So progesterone challenge test would be an option. And then if you think she might have PCOS based on what she's coming in with, particularly if she's also got some signs of virilization like hirsutism, or if she's got the acanthosis nigricans, that line on the back of her neck, you could consider drawing total testosterone, DHEAS, 17-OHP, cortisol, and the fasting blood glucose. So the testosterone, that would help. So that could be high with PCOS. It could also be high with like an adrenal or an ovarian tumor that was producing testosterone. The DHEAS would also be linked with an adrenal tumor, 17-OHP. You might see that being elevated with congenital adrenal hyperplasia. And again, these could also be elevated in the case of PCOS. And then cortisol, an adrenal tumor or Cushing's. And then, of course, that blood sugar, we would be wondering if there might be some insulin resistance. And then finally, this would be your baseline bleeding panel if a woman was coming in with really heavy periods. So heavy periods, just because it's a little bit heavy doesn't mean you're necessarily drawing all of this, but if she's got a family history of any of this, or especially if she's noticing easy bruising or bleeding, or like her gums bleed when she goes to the dentist, that kind of thing, then we might want to consider drawing these labs as well. Okay, and then we might also order some imaging. So here I've got pictures of a pelvic ultrasound. So there's a few different things this can look for. This can look for the presence of organs in the first place, if we're wondering about that, with congenital malformations. We can also look for an endometrial stripe. So ideally, if you can do it on cycle days 4 to 6, great. Again, if not, if she hasn't had a period in a long time, sometimes we don't have control over being that particular. But on this picture on the left here, around here, this is where her cervix would be. This is her uterus. Just outlined it. And then this here, this is her endometrium. You can kind of see 3 lines here. This is her endometrial stripe. So then they would measure the thickness from here up to here. So what's the thickest part? And then if it's cycle day 4 to 6, we would expect that to be about 4 to 8 millimeters. So on the one hand, we want a minimum in that shows that we have estrogen, we're producing estrogen. On the other hand, we don't want it to be really excessive either, like if we're concerned about perhaps unopposed estrogen. Or if you were debating if you should do an endometrial biopsy or not, again, they're pretty uncomfortable. You could consider doing this first. So if a woman seems like she might actually be at a really high risk for endometrial cancer, like if it's somebody in menopause who's then started rebleeding again, you'd want to go right to that endometrial biopsy. But if you felt on the fence about it, maybe she's 32, and you have some other things that might be the cause, and you're not sure you want to go all the way that far, you could do this first, and then if this is big, or a large number, then you could do the endometrial biopsy. Just to give you a sense of how it can be bigger later. So the first half of the cycle, day 4 to 6, that's going for the heart of the proliferative phase, the first half of the cycle. The second half of the cycle is the secretory phase, right? And then that we'd expect it to be about 8 to 14 millimeters. So there is a range to it, especially if you don't know when in your cycle you're getting it, if your cycles are irregular. So just keep that in mind. I would also be able to show you potentially polyps or cysts or fibroids. So in this picture here, this is her cervix, or actually this is her vagina here. This is her cervix, and then this is her uterus. And we've got a really big fibroid right here, and then we've got another smaller one here. So the angle of her uterus, this is her vagina, this is her cervix, and then this is me running through the center of her uterus. That white line is kind of your guide for what's in the middle. So you can see that this really is huge when you compare it to the other side, especially. Primarily it's in the muscle, but just know that the fibroids, polyps, cysts, adenomyosis, endometriosis, all of those are coming up in a different week. So we're thinking we have them on our differential for this week, but we're not going to be talking about management plans around those. So know that more content on those will still be coming. Another option would be a hysterosalpingogram. So basically what this is if this is a woman's vagina, right, a dye is inserted, and then diagnostic imaging shows us where that dye is. So say a fallopian tube is blocked, maybe she has a history of chlamydia 3 times or something like that, like especially if we're working somebody up around infertility, then we might find that the dye doesn't go all the way through. And then here's another picture of that where the dye actually showed that we have a bicornuate uterus. So you can see how it could be useful for a few different things when assessing somebody's basic anatomy. All right, so just as a brief review then, let's think about what's on our differential diagnosis list so far. So we've already touched on basically all of these, but anybody coming in, we want to make sure it's not pregnancy. Lactational amenorrhea is a possibility too. She hasn't gotten her period in a long time. If she's nursing, that's probably why. Thyroid could be hyper or hypothyroidism causing a change to menstrual flow. Hyperthyroidism could cause you to not have a cycle, but generally speaking, hyperthyroidism would cause heavy periods, whereas hypothyroidism, no periods or irregular periods. Pituitary, if we have hyperprolactinemia, so our prolactin level comes back high, it could be due to brain tumors, necrosis, injury, so that's going to be on our differential list. It could be drug related, so both cannabis and cocaine can cause irregular menses. And then of course, if she's on contraceptives, then that could certainly be a cause too. Depending on what she's on. So like if she was on, say she's recently stopped being on combined oral contraceptives or progestin-only pills, it generally takes about 1 to 3 months for her to get back to baseline. Whereas if she recently stopped Depo-Provera shots, that can take 6 to 12 months before somebody starts having regular cycles again. So that would be important to keep in mind. And then for hypothalamic amenorrhea, that could be due to eating disorders or intense athleticism would be something to think about. Certainly chronic disease or stress could play into it as well. Like just think about celiacs, for example. With celiacs, there can be malnutrition, and then that can influence somebody's cycle. Mood disorders can influence the hypothalamus as well. Poorly controlled diabetes, that can lead to low FSH, LH, and estrogen. Congenital syndromes, same thing, low FSH, LH, and estrogen. And then premature ovarian failure or menopause, because premature ovarian failure would basically present like menopause. That would be on your differential. So be thinking about how each of these patients might look a little different, and some of them you might not know until they you get their labs back. But somebody coming in with premature ovarian failure, she may have symptoms of menopause. She may be having hot flashes. She may have pain with sex because she's dry. And then when you draw her labs, you would expect that her FSH would come back as high. So thinking about kind of what's that whole clinical picture. We're not drawing all labs and doing all diagnostic imaging on everybody, but think about what would apply to each person's history and how you might draw labs or do things differently based on that. And then adrenal function, it could be PCOS, it could be a tumor, it could be obesity. So again, your labs would give you a better picture of that along with your physical exam if you saw evidence of virilization. Okay, a few more differential diagnoses here. So we have our coagulopathies. Again, thinking about if her bleeding's really heavy, we might explore that for labs. And her history may also indicate that. Anatomic abnormalities, such as absent ovaries or uterus or an imperforate hymen. And then we could have cervical abnormalities, like an infection, polyp, carcinoma. So again, that's why you might consider doing a PAP. And then uterine abnormalities, lyomas, adenomyosis, infection, polyps, endometriosis, endometrial hyperplasia, and carcinoma would all be possibilities. So again, common things happen commonly, but sometimes we do need to rule out the zebras, and sometimes the zebras are more likely to potentially be our horses. So we're sifting through all of these things and doing what makes the most sense in terms of working somebody up based on what her history looks like. And as midwives, we are trying to do the least amount and yet still be able to provide good and competent care. So we don't need to order everything right away, but making sure that what we're ordering is making sense based on her clinical picture. Okay, so management plans. For all of us, it's really important that you understand what our underlying diagnosis is before we start treating. So for example, if you've got somebody who's 47 who's having some breakthrough bleeding, if we started her on combined oral contraceptive pills, that would probably regulate her bleeding, but it could mask the fact that she might have endometrial cancer. So depending on what somebody's coming in with, we need to find out why that's happening before we start managing it. Or at least rule out that it's not something concerning before we start managing it, because a lot of these diagnoses are rule-out diagnoses, and it's not everything bad we know it is, so we're just going to treat it. Okay, so amenorrhea. What would a plan look like for amenorrhea? So if it's primary amenorrhea, you basically have two options. If all her tests are coming back normal, you've done some diagnostic imaging, you've also done a bunch of labs, all of that's looking normal, you could either consider watchful waiting, as in she's 16 now, but maybe in 3 months she's going to have her period, or you could consider a specialty referral, and they might do some karyotyping along with some other things to see if they can figure out what's going on. I would lean more towards 2, but depending on who you have in front of you, depending on maybe when she started having breast development, those sorts of things, you can look at the gestalt, and watchful waiting might be appropriate. For secondary amenorrhea, we definitely want to spend a little bit of time doing some lifestyle coaching. So thinking about appropriate diet and exercise, and psychological health. I don't know if you guys have heard of the female athlete triad, but that's basically where you have disordered eating, and that comes alongside amenorrhea, and that comes with osteoporosis. So those are the 3 things you find with the female athlete triad. So especially if you know you have one of those things, consider exploring the other ones as well. And for each of those, talking about ensuring we've got a good healthy diet and making sure we don't have any kind of an eating disorder, we might be referring people here. So we might refer to nutrition counseling, we might refer to psych, we might start treating something related to psych. So based on what's going on, if there's underlying anxiety, you could be treating that. If it seems like the eating disorder, at the very least, is probably going to be a counselor, but probably will be more, and you'll probably refer out for it. depending on what it is your practice is taking on. Now that might be something that would certainly be within your scope to treat, but that would probably be something where you're getting some extra training and you're in a clinic that's designed to really support that well. Let's see, PCOS goals. So if where you've landed is PCOS, which PCOS is addressed in more than just this lecture, but the main goals we have are to decrease insulin resistance. So you might start her on metformin, and sometimes that alone is enough to help with menstrual cycle irregularity too, as well as helping improve fertility. So I didn't add fertility as a goal, but if that's one of her goals, you would add that to here. Regulate menses, and this is important because sometimes women with PCOS can go months without a period, and that puts them at risk for having unopposed estrogen. So if they're not regularly ovulating, then this is a risk. So you could put her on any kind of contraception, really. We're just not wanting her endometrial lining to build up too much. If she says, honestly, I don't want to be on birth control, you could consider like 3-4 times a year having her take progestin for a week and then having her have a withdrawal bleed so we don't have that endometrial lining just continuing to build and build and build, and then just keep going. So every 3 months she does a week of progesterone, and then she has her withdrawal bleed, and then she goes on with her life. That's an option. Otherwise, she could be on pills, patch, ring. It could just be an IUD with just progesterone. But either way, however you choose to manage it with her, that's just ensuring that her endometrial lining isn't unchecked. And then that last goal would be decrease androgen excess. So this really depends on who she is in front of you and what her needs are. But if she does have a lot of symptoms of androgen excess and is wanting to address that, you could prescribe spironolactone, for example, or maybe she looks into laser hair removal. You can also prescribe creams related to decreasing facial hair. The downside to those is that as soon as you stop using them, they don't work anymore. But that would also be an option. So a few possibilities there for PCOS. We're just wanting to for sure make sure that she's having a period at least every 3 months or so. For thyroid, you can absolutely manage that yourself, or if it seems particularly complex, you could certainly refer to endocrinology too. Hypoprolactinemia, you could consider retesting before officially diagnosing it, especially in the morning. Sometimes if they've already been going about their day, that can cause levels to naturally be a little bit higher. So you could check first thing in the morning before she's eaten to confirm it. And then if it is high, you could order an MRI to be looking for tumors. And probably at the same time, you're also referring to endocrinology to do the ongoing management for that. In case she's asking questions, though, for hypoprolactinemia, if they do find a tumor, it's almost always benign and not concerning. And generally what they'll do is they'll prescribe a dopamine agonist. And most women will do that for a couple years or so. And then they'll taper off of it. And if they're good to go, they're good to go. Sometimes they have to do surgery, but usually the dopamine agonist is enough. I think not that we are typically the ones doing that management, but since women are usually in front of us when that's first diagnosed, it's helpful for us to give them some anticipation. And then premature ovarian failure, likely they're going to need to be on hormone replacement therapy because, like, say you do have a woman essentially going through menopause at age 28 or 30, her risk for cardiovascular disease and osteoporosis is going to be quite a bit higher to have so little estrogen for so much of her life. You could do that with just prescribing normal contraception, so that would be a way to do that. But she may come back to you for that, but she's probably going to be transferred out or referred out to have a really full workup, since that isn't common to go through premature ovarian failure. To officially diagnose it, make sure there isn't something else going on, and then hormone replacement therapy, which we'll get into later in this semester too. So your basic therapy across the board for amenorrhea is just going to be hormonal contraception. So assuming that maybe you found that it is her thyroid, you're working on getting her thyroid back, you could be doing hormonal contraception to start to regulate her cycle if that's not kicking in very quickly. Or for any of these issues, whatever the reason is, as long as that's being addressed, hormonal contraception is a way to get her cycles more normalized again. And you could do that in a lot of different ways. So you can refer back to last week what all her options could be. But all of that is going to bring some regularity to her cycle. Now, if her situation is highly complex, this is absolutely something that you can be referring for, particularly if it is involving chronic diseases alongside it. All right, dysfunctional uterine bleeding. So these are our particularly heavy periods or our irregular cycles, and they oftentimes will come together. And again, as a reminder, we're not starting out with a plan until we have a sense of what might be causing it, or at least ruling out that it's not something concerning. So if cramping or heavy flow are a big part of the dysfunctional uterine bleeding that your woman has, NSAIDs are a great option. They're not just for pain, we know them in that context, but they also reduce menstrual flow. So on average, they'll reduce flow by about 20 to 50%, and that assumes that she's taken it kind of around the clock for 2 to 3 days at least, or through her whole menstrual cycle if it's lasting longer than that. So at least a solid 2 to 3 days worth of taking it is going to significantly reduce her total flow. And I'll just say that for all of these, we're not going to be doing all of them, so you pick what makes the most sense based on the severity of her situation. So then hormonal contraceptions are also a great option. On average, they're going to reduce menstrual flow by 40 to 70%. So again, heavy periods, COCs are a great option. And then also if they are irregular, if they're irregular and we've confirmed that there's nothing dangerous or concerning about the irregularity, then hormonal contraception will bring regularity, and it will also reduce her total flow. So another great option, and if she's needing contraception anyway, then this is the perfect way to go. So you do want at least a little bit of estrogen here because we're wanting to be able to build up a sufficient lining. So 30 micrograms of estrogen would be a good place to start, and then if you needed to increase it, you could increase it, but starting with 30 in this case is a good place to start if you're doing oral pills. But you could also consider a progestin-only method, or the patch or the ring would also work in this case. So any of those options would be appropriate. If you do a hormonal method that just has progestin, you could think about, like, say she's got really heavy periods to the point where she's super anemic. You might even consider doing depot shots. They're not my favorite, but most people end up with very little to no flow. So depot shots would be an option. The Mirena is approved specifically for menopause by the FDA, so that's a great way to reduce menstrual flow. After a year of use, the Mirena reduces menstrual flow by about 85%. And a lot of those women will actually not even have a period. I think, so Mirena says about 25%. In my experience, it's been quite a bit higher than that. So 85% of people will have improvement by a year with the Mirena. Yep, so you've got a lot of options for how you could go about doing that based on what fits her lifestyle and what she's looking for too. Iron supplementation would definitely be something you want to consider if she is anemic. I don't even know that I had CBC on your lab list. I remember thinking I wanted to add it, and now I can't remember if I did. But a CBC would definitely be something that you would want to draw if you were expecting heavy blood loss, and a ferritin too would be a good idea to check her stored iron if you were expecting that it was going to be heavy. So you could do iron supplementation as needed based on what those results were. And then for the most part, that's going to be all you really need to do is right there. So if NSAIDs weren't working, I guess the other thing I was going to say for hormonal contraception is not every woman can be on estrogen, so definitely consider progestin if the woman in front of you is going to risk out from or not be able to use estrogen if that's going to be a contraindication for her. So 3 other options that aren't as popular for a number of reasons, but definitely you could consider if NSAIDs weren't enough, if hormonal contraception wasn't enough. I mean, people with DUB, it can be enough where they can't go to work for almost a week every month. So if it's severe and these aren't working, which usually they are, then here's some other things you could consider. So there's antifibrinolytic agents, though you'd want to consider the increased clotting risk there. That makes them a little bit less popular. GnRH agonists are pretty expensive and essentially induce menopause. So again, based on her age, based on what she's wanting for child rearing in the future, and then also thinking about side effects. Menopause often comes with side effects, thinking about estrogen depletion, so but a possibility. And then for danazol, that's going to suppress estrogen, which in the same manner then side effects are potentially virilization, so things like hirsutism, that kind of thing, and then also thinking about the risk for clotting. And that can be somewhat expensive as well, but all of those medications would be possibilities. And then even looking more on the severe side, you could consider, I don't mean severe treatment, I mean if her condition is severe, you could consider referral to an OB for surgical ablation or a hysterectomy, where basically here they're like cauterizing off some of that endometrium, so it's just not even growing and shedding every month. And then sometimes a hysterectomy is needed too, or fibroid removal. It just depends on what her situation is. Lastly, let's look at an example of a plan for primary dysmenorrhea. So secondary dysmenorrhea, again, we'll cover that in a different week. So issues like endometriosis and fibroids, etc. But for primary dysmenorrhea, again, that would be somebody who is having cramping leading up to and during her cycle, and it's not caused by any kind of pelvic pathology. We can counsel her about lifestyle. So we know that people who have low BMIs and higher BMIs, that can worsen it. So talking about getting to a healthier weight potentially can make a difference. Smoking worsens it as well, so potentially this might, depending on the severity for her, this might be a motivator for her to quit smoking. Addressing anxiety and stress and depression, because all of those have been found to worsen dysmenorrhea and are linked with dysmenorrhea. And then exercise can really be helpful. So exercise decreases prostaglandin release, and we know that prostaglandins are a big part of what's causing dysmenorrhea. So it decreases prostaglandin release, and it's increasing endorphins, so that can really be a helpful way to manage dysmenorrhea as well. So we're counseling on those. And then for diet, I just gave it its own subpoint. So limiting sodium in animal fats. Animal fats are high in prostaglandins, so especially the second half of her cycle leading up to her period, that would be the time when she shouldn't be eating a lot of bacon and sausage and foods that are high in animal fats, because that will enable her body to synthesize more prostaglandins, which will be harder on her cramping. And then increasing fiber, so lots of good fruits and vegetables and water would be how we're wanting her to focus her diet. And then first line medication treatment would be NSAIDs. So NSAIDs have a 70% success rate. And how you want to think about it, NSAIDs are helpful for a couple reasons. So first off, obviously they're helpful for managing the pain itself, but NSAIDs also prevent the synthesis of prostaglandins. So to really utilize them to the max, she could take it a couple days before she's expecting to get her period. Or sometimes people have just kind of the smallest little bit of cramps a day or two before their period. We're trying to get before then. So say she takes 600 milligrams of ibuprofen 2 days before she gets her period, and then takes another 600 milligrams as soon as she gets her period. That may be enough to just last her for her period, where she's not even needing to take it around the clock, where she may have needed to do that continuously before. So that's a good way to use NSAIDs, and then obviously be counseling around taking it with food and discuss some of the side effects and things like that as well. So first line is NSAIDs, and then hormonal contraception is another big piece that can be helpful for dysmenorrhea. So for those that already need contraception, then this is a good way to go. If not, though, this may still be what fits her lifestyle the best. So contraception has been found, hormonal contraception has been found to be 90% effective. And then you could get creative with it. So depending on how bad her dysmenorrhea is, and I should say this is the same for women with really heavy cycles too. So menorrhagia or dysmenorrhea. You could consider doing extended cycles or continuous cycles for the hormonal contraception. So, for example, when she gets to the placebo week, she could skip it and start her next pack and just go straight through without having a withdrawal bleed. Or if she's on the NuvaRing, usually you put it in for 3 weeks, take it out for a week, and then start the next one. She could just leave it in for 4 weeks, take it out, put a new one in same day. And then she wouldn't even have that withdrawal bleed. Same as thinking about women with PCOS, it's a good idea to have a withdrawal bleed every 3 months just so that we know that that endometrial lining isn't continuing to get thicker and thicker. But even with COCs, that's not as necessary in that you are giving her progesterone. So it's containing both estrogen and progesterone. So that's not so much of a concern because it's already being opposed. That estrogen is being opposed. So feel free to be creative. Depo and Nexplanon also seem to be good options. Not a lot of research on that, but it makes sense if we're decreasing our bleeding in the first place, that it's also going to help with cramping. And then the Mirena. Mirena has about a 50% reduction for those reporting menstrual cramps with their periods. Obviously, some people can be kind of crampy just having an IUD in the first place, but this is still a good option, and most people don't. So once their bodies have kind of gotten used to that IUD for the first week or two, in terms of it finding a good place to kind of get settled, there doesn't tend to be cramping. Again, that's the Mirena, not the Paragard, because the Paragard could be our cause of dysmenorrhea. And then turmeric, I thought kind of interesting. I haven't seen any research studies looking at turmeric in the context of menstrual periods, but I have seen it used head-to-head with NSAIDs for other conditions for managing pain and inflammation. And turmeric actually performed as well as NSAIDs, and then users liked it even better than NSAIDs because it didn't have all the GI side effect profile. So now I have to remember how many milligrams. I think in that context that people were taking 1,000 milligrams, but that would be an option, and even just recommending women cook with turmeric would be another option. Magnesium research goes back and forth a little bit, but it's a smooth muscle relaxer, and would also be worth exploring, especially if somebody's looking for some more natural ways to manage it. Magnesium, you do kind of max out with how much you can take orally and have your body still be absorbing it well. So I recommend women consider taking like an Epsom salt bath, because that is magnesium salts, and then they can absorb it through their skin that way. And warm water is already a great way to help with dysmenorrhea, right? I mean, this slide doesn't even talk about hot and cool therapies and hot water and all just the little lifestyle things that can be helpful there. So a warm bath with Epsom salts could be helpful. And then you can also get magnesium-based lotions that have them in it. So again, letting your body absorb it through the skin. And most women are pretty low in magnesium. So anytime anything might be linked with magnesium, I encourage people to get a little bit more in one way or another. Headaches is another one I see for primary care quite a bit, where magnesium can be helpful. B1, there's also some research on taking B1 as a supplement that actually does look pretty promising, and same for fish oil. And again, all of those, I would say, it's not like as a provider I can say we've got a bunch of randomized controlled trials on this, and across the board we're seeing that it's the new drug of choice. I can't say those things, but in terms of some natural complementary medication being helpful to supplement alongside other things. They're certainly not harmful, and if that fits well with what a woman's goals are for her health care, then that might be a good option for her to explore. So lastly, this is fresh from today. I just took this picture today, and I thought I would end with a little case study. My chickens, I got 3 of them last April, and they are supposed to start laying after about 6 months, and it's been 9 months, and I hadn't gotten a single egg until today. And as I was preparing this lecture, I thought, I need to diagnose my chickens with primary amenorrhea. We have a problem around here. So I didn't draw any labs, but I did think about their diet, and I didn't think they had too much exercise, but I did make sure they had plenty of calcium in their diet. And ultimately, I think for them what happened was most chickens, when there's not as much sunlight in the winter, they tend to slow down laying, or even some will take a break for winter until the sunlight kicks back in and their days are longer. But in the case of my chickens, I think right around the age they would start laying was when the days were just starting to get shorter, and that was enough to just leave them dormant all winter. But now that it's starting to warm up a little bit, it's February, but it is warming up a little bit, they've started laying. So a case study that meant watchful waiting was the key. So that was ultimately the therapy for my chickens, was watchful waiting. And I think actually it's probably only one of my 3 chickens that's actually laid all 3 of these. So continuing to do watchful waiting for the other 2. But to the extent that that gives you some hope to trust in what's natural, take that for what it is. Sometimes all little watchful waiting is all we need. Anyway, I hope you guys find some good rest this week, and as I was looking at this picture, I was thinking about a few times in the Bible where it talks about God wanting to gather his children together the way a hen gathers her chicks under her wings. So I just pray for you guys this week that you would lean into him and that you would just accept rest. So I hope that you guys can end this week with blessings. And I wanted to finish up this lecture by reading to you the Beatitudes in one of my favorite versions for the Bible. So we'll end with that. So the version is the Message, and it's titled, You're Blessed. So when Jesus saw his ministry drawing huge crowds, he climbed a hillside. Those who were apprenticed to him, the committed, climbed with him. Arriving at a quiet place, he sat down and taught his climbing companions, and this is what he said. You're blessed when you're at the end of your rope. With less of you, there is more of God and his rule. You're blessed when you feel you've lost what is most dear to you. Only then can you be embraced by the one most dear to you. You're blessed when you're content with just who you are. No more, no less. That's the moment you find yourselves proud owners of everything that can't be bought. You're blessed when you've worked up a good appetite for God. He's food and drink and the best meal you'll ever eat. You're blessed when you care. At the moment of being careful, you find yourself cared for. You're blessed when you get your inside world, your mind and your heart put right. Then you can see God in the outside world. You're blessed when you can show people how to cooperate instead of compete or fight. That's when you discover who you really are and your place in God's family. You're blessed when your commitment to God provokes persecution. The persecution drives you even deeper into God's kingdom. Not only that, count yourself blessed every time people put you down or throw you out or speak lies about you to discredit you. What it means is that the truth is too close for comfort and they are uncomfortable. You can be glad when that happens, give cheer even, for though they don't like it, I do. All of heaven applauds, and know that you are in good company. My prophets and witnesses have always gotten into this kind of trouble. Let me tell you why you're here. You're here to be salt seasoning that brings out the God flavors of this earth. If you lose your saltiness, how will people taste godliness? You've lost your usefulness and will end up in the garbage. Here's another way to put it. You're here to be light, bringing out the God colors in the world. God is not a secret to be kept. We're going public with this, as public as a city on a hill. If I make you light bearers, you don't think I'm going to hide you under a bucket, do you? I'm putting you on a light stand. Now that I've put you here on a hilltop, on a light stand, shine. Keep open house. Be generous with your lives. By opening up to others, you'll prompt people to open up with God, this generous Father in heaven. Okay, I hope that was a blessing. Have a great week, guys.